Bismillah ar-Rahman ar-Rahim. Today we are going to discuss the conjunctival allergy and degenerations. The allergic conjunctivitis can be divided into acute allergic conjunctivitis, chronic allergic conjunctivitis, and the best example is the vernal catarrh, and the delayed hypersensitivity reaction, and the best example is the flectinular keratoconjunctivitis. In the acute condition, it is called acute allergic rhinoconjunctivitis and can be subdivided into SAC and PAC. The SAC is the seasonal allergic conjunctivitis, and the best example is the hay fever. You know, when a person goes to a garden and he is exposed to pollen grains, he can develop acute allergic condition. While the PAC is something which is not seasonal and is present all over the year. That's why it is called perennial allergic conjunctivitis, and it is mainly in the autumn and is due to the house dust mites that is present in the houses. Also, it can be caused by the smokes and the dust. In acute allergic conjunctivitis, it involves inflammation of the conjunctiva, which is the clear membrane that covers the eye. As we can see here, this eye is a red eye. There is also lacrimation as well as itching, and itching is something that is very important in acute allergic conditions as well as chronic allergic conditions. You have to know that every allergic condition will produce itching, except in the delayed hypersensitivity reaction, while all infectious conditions does not cause itching, except for angular peripheral conjunctivitis, which is caused by Morax Axenfeld. As we can see here, there is the red eye, and the patient will complain of itching and lacrimation. And in some severe cases, due to eye rubbing, development of chemosis of the conjunctiva will occur, as we can see here, and the chemosis of the conjunctiva is nothing but redundant edematous conjunctiva, as we can see in this picture. So the clinical picture of acute allergic conditions, high on the list is itching. So without itching, you cannot diagnose allergic conditions. And what's the cause of itching here? And through what is mediated the itching? The itching is nothing but subthreshold painful condition. So it is mediated through the pain receptors. So if you have an itchy part of your body, it is subthreshold pain condition that occurs in this area due to allergy or due to any other thing. Also, there is redness and watery eye. And the treatment is simple in such conditions. Be away from the allergens, and you can take antihistaminic, mast cell stabilizers, and we rarely use steroids in such condition. Now we will move to what we call the vernal catarrh. And the vernal catarrh has a special pathogenesis. It is immunoglobulin E and cell-mediated immune mechanisms that play an important role in the disease. It affects boys more than girls, and this is because boys are outgoing in the sun and dust more than the girls. It is more common in the sub-Saharan region in Africa. It is also common in Saudi Arabia, and the peak in the spring and summer, but we call it spring catarrh, and it took this famous name, and now we are not able to change it into another name, spring catarrh. There are three types of vernal catarrh. The first is the palpebral, and as we know, The palpebral means it is related to the lids. The second is the limbal or bulbar type, which is the disease that is related to the bulb or the globe itself. And there is the mixed type. The symptoms here are intense in everything, intense itching, intense lacrimation, and there will be a thick mucoid filamentous discharge that the mother usually describe it as the patient is getting something like a ropey discharge outside of his eye, and he is not relieved except when he gets this ropey discharge. And the signs are very pathognomonic. If this is the normal conjunctiva, as we can see here, these are the vessels that is parallel to each other, and we can see them clearly here when we evert the lid. While in the spring catarrh, we can see in the palpebral type what is called cobblestone papillae. These are nothing but giant papillae that coalesce together, and it forms a very aggressive itchy area in the palpebral area. You can imagine if this is the smooth surface that we are used to, and in such a condition, this is a very rough surface that whenever you blink, you'll find this rough surface disturb your eye. And the palpebral cobblestone papillae is very pathognomonic to the vernal catarrh or spring catarrh, but there is a differential diagnosis. We can find this in other diseases, such as um, if the patient is wearing a contact lens, the GPC, giant papillary conjunctivitis, due to contact lens wear, or if the patient is wearing an artificial eye, or if the patient is having atopic keratoconjunctivitis, we can see such a condition. Now we will move to the limbal vernal catarrh or the limbal spring catarrh. As you can see here, there is infiltration around the limbus. These are gelatinous masses full of eosinophils and inflammatory cells. These gelatinous masses increase more when the child goes outside in the sun and in hot climate. It increases to the extent that the mother notices that there is a white area that she is not used to see in her child eye. These gelatinous masses goes on and off. They increase in size and decrease in size when they are treated, but uh, there is sometimes what is called Trantas spots in these areas, and we can see them here. These are the gelatinous area, and this is the Trantas spots, as we can see. But sometimes we can see what's called a shield ulcer. As you can see in this condition, there is a mixed type. There is corneal manifestations as well as palpebral manifestations here, and this is called the shield ulcer. The shield ulcer is a sterile ulcer, and it's an exception of ulcers that is treated with steroids. So this ulcer will not heal except when we give the patient steroids. The rule is we should never give steroids to a corneal ulcer, especially if it is infective, but this is the exception of the rule, as we can see here in vernal catarrh, the shield ulcer responds well to corticosteroids. So the treatment of such a condition, such a chronic condition, you have to explain to the mother the disease, and The disease is not that harmful to the eye as the medications that we are giving to the patient, especially steroids. We have to use the steroids with very cautious use because the steroids can induce cataract and glaucoma if they are abused or if they are used without medical supervision. So we prefer to give antihistaminic, mast cell stabilizers, sometimes acetylcysteine that makes the ropey discharge thinner discharge. Sometimes we use cyclosporin, but we use the steroids with caution, and we have to tell the mother that this is a drug that is used for short periods. She shouldn't bring it from the pharmacy without medical supervision because it may be harmful to the eye of the child. Supratarsal injection, sometimes we are using it in severe palpebral condition because the giant papillae does not like go away easily with the topical steroids. So we sometimes refer to supratarsal injection of steroids. The systemic antihistaminics or antiprostaglandins sometimes are used topically or systemically. Now we will move to the third condition, which is the flictinular keratoconjunctivitis. The flictinular keratoconjunctivitis is nothing but uh, a delayed hypersensitivity reaction to a certain antigen. And in the past, TB was the most common cause of the flictinular keratoconjunctivitis, but nowadays staphylococcal antigens are the most commonly seen now. Also, sometimes we see this condition in kids with intestinal parasites like Ascaris and Ankylostoma. The types of flictinular keratoconjunctivitis is either conjunctival, which occurs anywhere in the conjunctiva, limbal, when it astrides the limbus, or corneal flictinular keratoconjunctivitis. And it is nothing but the pathogenesis of this is a reaction between the antigen and the antibodies that is sent by the immune system, and it is nothing but a pustule that is caused by this interaction between the antigen and antibody. And we will find that redness occurs around the pustule, and it is sometimes painful, especially when it astrides the limbus or it's in the cornea. But whenever it is in the conjunctiva only, it's not a painful condition. Usually, the mother comes complaining of a localized redness in her child eye, and you will be like a hero if you discover that the patient is having intestinal parasites. You send her to do the stool analysis, and she comes back with a positive result for intestinal parasites, and she will think that you are a good doctor. Now we are going to move to the degenerative conditions of the conjunctiva, and we'll start with what's called the pinguiculum. The pinguiculum in Arabic is called al-shahma. Al-shahma because it looks like a fatty thing here in the conjunctiva, in the nasal part of the conjunctiva. This is a very common condition. If you search in your friends around you, you'll find 10% or something like this of people in our area are suffering from this degenerative condition because we are exposed to UV light more than other people in Europe. But exposure of the ultraviolet, of A ultraviolet and B ultraviolet rays can cause this elastotic degeneration of the conjunctiva. Why we call it elastotic degeneration? Because it simulates the elastic tissue. In what part it simulates the elastic tissue? It is a coil-like degeneration of the collagen. Well, it's supposed that the collagen is something that is straight, lamellae, but if it is coil-like, it will simulate the elastic tissue. But if you stain them with special stains for the elastic tissue, they don't stain. So we call this elastotic or elastoid degeneration of the conjunctiva. What are the characteristics of the pinguiculum? The base of the it's triangular in shape with the wide base towards the limbus, and this is contrary to the pterygium. In the pterygium, the base is away from the limbus and the apex is usually at the limbus. As we can see here, the base of this pinguiculum is towards the limbus, so the white area is near the cornea. And this area sometimes will be elevated above the surface to a certain extent that it causes dryness of this area, and it is called delen. Delen is an area of desiccation or area of dryness in the cornea that causes a facet or thinning of the cornea in this area without staining. So sometimes also there is inflammation of this pinguiculum, and we call this condition pinguiculitis. There is a localized redness here that responds well to steroids. There is no need to treat such a condition, but if you are seeing a patient with such a condition, you advise him to wear sunglasses to protect his eye from UV light. Because if he is not protecting his eye, this may proceed to develop what's called a pterygium, as we can see here. And the pterygium is nothing but the same elastotic degeneration that occurs in the conjunctiva, along with failure of the stem cells here to cover the corneal epithelium with the normal epithelium. So this area of the conjunctiva will try to cover this area that is not covered by the stem cells here. And the failure of the stem cells occur because of the exposure of the UV light. As we can see here, usually the pterygium is nasal and it is triangular in shape, and the apex of this pterygium is towards the cornea, while the base of the pterygium is away from the cornea. As we can see here, there is blood vessels in the pterygium. That's why it is usually aggressive. If we remove it, it usually tends to recur, and this is the big problem of pterygia. So, what can we do to remove this unsightly lesion in the eye without getting a recurrence with this aggressive tissue? So, we have some indications of surgical excision, indications of surgery. If the patient is not happy with his appearance of the eye, so for cosmetic reasons, we are removing many pterygia. Or if it is endangering the pupillary area, if it is coming near the pupillary area, we have to remove it before it covers the pupillary area. Or if it is causing high astigmatism that affects the eyesight. These are the indications of surgery. If it is a very small one without any progression, we ask the patient not to worry about it and just for follow-up. So, what we can do to excise this without getting a high rate of recurrence. First of all, we can do what's called the Beres-Clera technique. And in the Beres-Clera technique, we remove this area, all this area, until we see the sclera. We remove it either antegrade or retrograde. So we can come from here and remove the pterygium antegrade from here to here. Or we can go from the backward area here. We start here and we reflect it and we remove it retrograde. I prefer now the retrograde dissection. It is safer for the cornea and we get a better dissection. When we remove the pterygium, what can we do? Either you can put here mitomycin C, a solution of 0.04% for 3 minutes, and we all know that the mitomycin C is antimitotic. It will prevent rapid recurrence of the pterygium. Also, we can use the beta irradiation with the strontium bars that will cause the beta irradiation will cause vasculopathy. So it will occlude the blood vessels that is supplying this area with um, feeding, so it will not recur rapidly. But the patient will need like 3 or 4 or 5 sessions of this beta irradiation post-surgery. It is time consuming, of course, so we are now using more the mitomycin C. Or we can do what's called a free graft. We can take part of the normal conjunctiva here and part of the stem cells from here, from the above, and we can rotate this flap, free graft, to put it here in this area that we left it bare. So instead of leaving it a bare sclera, we bring a part of the conjunctiva from here with the stem cells from here, and we put it in this area to make sure that this area will form new epithelial cells before any recurrence. And this can prevent recurrence of the pterygium in higher percentages. So what is the operation is like? It's like the section of this area, which is larger a little bit than the area dissected here, and we bring it and we suture it from here, here, and here, with leaving this area without sutures because we don't want to injure the stem cells. With this technique, we have less recurrence of the pterygium. How can we differentiate between a pterygium and a pseudopterygium? A pseudopterygium is nothing but a fold of conjunctiva that came and was sticking to the surface of the cornea, but it is not a degenerative condition of the conjunctiva. With the pseudopterygium, consider that there is a fold of conjunctiva that came and was sticking here, but you can pass a hook behind it. So this is the differentiation between the pterygium, true pterygium. You cannot insinuate a hook beneath a true pterygium, but you can do this in pseudopterygium. This is a common question in the exams. How can you differentiate between a pterygium and pseudopterygium? What are the indications? How can you prevent recurrence of the pterygium? I hope you enjoyed the lecture, and this is Bibliotheca Alexandria. I wonder if any of you have visited the Bibliotheca of Alexandria and visited the planetarium, I encourage you to do so. Thank you very much. I'm Ahmed Shama. And if you have any questions, I'll be delighted to answer any questions for you. This is my email. You can email me at any time. Thank you very much and see you